A 45-year-old male came to ER with alleged history of accidental ingestion of caustic soda as he mistook it for sugar yesterday night at around 12:50 a.m. He chewed a mouthful of it and spat it out immediately when he realized it was not sugar. Patient came to ER with complaints of oral cavity edema, swelling of lips, and there was hoarseness of voice along with drooling of saliva. No history of vomiting, cough, breathlessness, altered sensorium, epigastric pain. On initial 10-second assessment, patient's airway, patient had drooling of saliva with edema of the tongue and lips. So in view of impending airway compromise, we went ahead and we intubated the patient. Coming to breathing, airway, bilaterally air entry was present with a respiratory rate of 20 breaths per minute with saturation of 99%. Circulation wise, BP was 130/70 with a pulse rate of 79 per minute. Disability was, on arrival, patient's GCS was full. Exposure and temperature of 97°F. Following this, we went ahead with sending the routine labs of the patient. Also, we gave a gastromedicine consultation as we wanted to do an endoscopy to look out for any esophageal perforation or any strictures that the patient might have developed.
Okay. So right now,
patient is going to be taken up for endoscopy.
Okay. So any patient who presents to ER with acid or alkali ingestion, so we'll just use alkali ingestion. What are the basic things that you have to keep in mind? What are the important things? So if a patient has consumed alkali, what happens? What are the symptoms?
Burning, pain.
The alkali reaction will start from the moment it touches the skin or mucosa or lips or whatever it is. It starts instantaneously. Within seconds, the entire cells are getting involved. So it's not like a progressive condition that will happen over time. It has already happened. So patient is coming to you with the worsening of symptoms. Patient will initially say that I had pain initially, then my swelling started, redness started, drooling of saliva started, I can't swallow, it's odynophagia, difficulty and painful swallowing is there. All these symptoms will worsen, but the injury has already happened. Okay, so the extent of injury will directly be proportional to the strength of alkali. So we need to know what type of alkali the patient has taken, whether it's a weak or moderately severe or a very highly severe alkali. Ideally, the pH of the alkali is what we want. Rather than a classification of mild, weak and strong, if you have a pH classification, it will really help us to identify how much of extent of injuries we are expecting. Now, what is the type of injury that alkali does?
Liquefactive necrosis.
Liquefactive. So what is the type of injury that acid does?
Coagulative necrosis.
Coagulative. So we have two words now: liquefactive necrosis and a coagulative necrosis. What does it mean? What is coagulative necrosis means?
It will clump the proteins.
Yeah. So it's acids basically cause severe intracellular dehydration, cellular apoptosis, and everything is clumped together. That is coagulation that happens. So at the end of the acid burn, what you have will be a charred mass, okay? Hard charred mass with ulcerations. What is liquefactive necrosis means?
Denaturation, lipid.
Basically, alkali reacts with the lipids and cells are being destroyed from outside, but the difference between coagulative and liquefactive necrosis is when alkalis are doing liquefactive necrosis, it helps them to go deeper into tissue. So entire tissue sections can be directly involved. Coagulative necrosis will prevent further acid burn at a point. Once that coagulative necrosis sets in, further acid exposure will not cause much of damage, but whatever damage happened would be extensive, but further damages may not happen. So patient will have a lot of damages superficially, which can extend to significant levels, but full thickness exposure is very unlikely in acid burns. But in alkali burns, patient will keep on going into liquefactive necrosis of the entire thickness as long as patient is exposed to alkali. So our primary management will be to rid of the patient of anything that has a exposure to the alkali. So in this patient has taken that alkali tablet, right? Tablet
like
and spit, and he has chewed on it and spit it out. But unfortunately, if this patient took it as a form of water, like mixed in water or something, or drank from a alkali that is kept outside, he might have spillages on his shirts and his dress, and so those things has to be removed because a continuous exposure can happen from them. So first is obviously our safety. So proper PEP equipmentation is very much necessary in this case. Take care of your part, then decontaminate the patient, remove the ongoing exposure of the patient, and then you need to wash the patient, and continuous irrigation has to be given because if at all patient is having ongoing exposure. Then the next thing comes. When we say next thing, it's not like only after that you need to treat. Simultaneously you need to make a decision, and the decision is always about airway. Decision is always about airway, especially in a patient who has consumed or ingested alkali. It's always about airway. More the time spent after the ingestion, more necrosis would have happened and tissue integrity will decrease. So whatever procedures you want to do, the ideal time to do the procedure is then. More time spent, tissue integrity comes down and tissues will become friable. For example, if this patient was treated outside, I'm referring to you in 16-18 hours saying that patient is having worsening of airway compromise and will have to intubate. You try to intubate like after 18-20 hours, most probably the patient's tongue, oral mucosa, lips, everything will start disintegrating and patient will start profuse bleeding, and your procedure itself will become very difficult. So in airway of these patients has to be managed when they present itself. You need to make a judgment call whether this patient has immediate airway danger or not, and that danger doesn't mean patient has airway occlusion. Question is whether patient will go into airway occlusion. So what are the main things you will look for airway occlusion?
Patient will have stridor, hoarseness of voice.
Patient stridor is there, but let's start from the outside.
Okay, edema
of lips. Basically, since edema of lips, your oral opening will narrow down. Your oral opening narrowing down will restrict your view. That is first thing. Second thing,
swelling of tongue.
Swelling of tongue, big tongue. Bigger the tongue becomes, difficult instrumentation, the narrowing of airspace. Tongue may not be kept out of visual field. Okay.
Laryngeal edema will be there if yes.
Pharyngeal edema, laryngeal edema. Because of these edemas and ulcerations and liquefactive necrosis, there will be a lot of secretions in the oral airway. There can be pooling of secretion. There can have active bleeding. If a patient has taken significant amount, it can cause hard and soft palate ulceration, oral ulcerations, tongue ulceration, which can cause bleeding. So saliva pooling, blood pooling can be seen in oral cavity. That has to be expected. And then coming down, you may have vocal cord edema due to vocal cord burns in the vocal cord or in the larynx or in the esophagus. Patient has ingested. If at all some drops have gone into larynx, patient will have significant laryngeal irritation. Dry coughs can be there. Laryngeal cord edema can be there, and esophageal edema can be there. Similarly, patient can also have epiglottal edema. Because of epiglottis edema, epiglottis will be bigger and maybe obstructing your view. These are the airway compromises that you can see in these patients. But if at all you are seeing at least 2 or 3 of these complications, along with some hoarseness of voice, it's always better to go ahead and intubate the patient as early as possible rather than wait and watch. Main issue of wait and watch is that there is no treatment that we can give to reverse this. This thing has to settle by itself. So airway securing is the most important part. So When you secure airway, what are the means in which you can go ahead and secure airway?
We have to arrange a tube size which is smaller than the actual requirement of the patient
Yeah.
because edema is there. So we have to anticipate a difficult airway.
Yeah, instead of your usual sizes, at least a half a size lesser tube and a one full size lesser tube should be kept ready.
Other than that,
Other than that, early intubation can be used done by normal laryngoscopes, but ideally a video laryngoscope will be much better, because if at all patient is having significantly big tongue, swollen lips, oral opening might be restricted, and even if you are forcing it open, patient will have severe pain. If you have a video laryngoscope, manipulation of mandible is very limited. So you can do the intubation without much manipulation, which can prevent bleeding and better visualization. So video laryngoscope will be ideal in this situation. But if this patient is coming and you have time with you, like patient is early, like patient has ingested and came to you within like minutes, patient is not having any airway occlusion signs right now, but there is some lipedema, some tongue swelling and all. What is the ideal way of airway securing?
flexible bronchoscopy.
Flexible bronchoscopy. Flexible bronchoscopy will let you do two things. One is intubate and secure the airway and assess the trachea, or of means pharyngeal wall, larynx, laryngeal cords and trachea. So you can see whether any tracheal damage is there, tracheal ulcerations are there. Those things you can know. But that is only to be done when you have time with you. When patient is in airway compromise, you should not go for tracheal flexible bronchoscopy. Okay, so that part is in airway. What airway adjuvants can you use in a alkali burn case? Airway adjuvants are one of the most, it's not going to help you out as such. Mainly what we say as airway adjuvants is LMA. When you have oropharyngeal airway, you can't put. Nasopharyngeal airway, you should not put. Why?
Blind.
Nasopharyngeal airway, you should not put. Any reason? Especially if a patient has consumed alkali in the liquid form. How does strong alkali and strong acid appear? Fumes. So it's not only ingestion, there will be fumes. Since fumes are there, the fumes can enter your nostrils, nasopharynx, lungs and cause extensive damage as heat itself. So burns will be there. So when a patient has ingested alkali, you should not use nasal airway as such. And nasal airway is not going to help you out also. You will require intubation. So LMA may not help you out here, because even though patient size is significantly bigger, there will be significant edema of the oral cavity, which will prevent
entry of the
LMA insertion and usage. So that's it with airway. So what in breathing? What are the complications you will expect in breathing?
Patient might have aspirated. So
patient must have aspirated. There can be lung collapse, chemical pneumonitis can be there. In strong alkali, strong acid cases, chemical pneumonitis will be very fastly presenting. In that cases, patient will require high flow oxygen, NRBM, and once intubated will require high FiO2 levels. If at all patient has ingested fumes, chemical pneumonitis is there, ARDS like features can set in very rapidly. In that condition, low tidal volume ventilation has to be given. So that is in breathing part.
Circulation.
What about circulation?
Patient might have shock, may develop shock in case patient has gone into perforation. If bleeding has occurred, like GI perforation, GI bleeding occur, patient may develop a shock.
So any patient who has acid or alkali ingestion presenting to you with shock, there can be two reasons for shock. One is basically the shift of fluids, extravascular shift of fluids that is being used up, and basically burn induced dehydration. So hypovolemic shock has to be expected in these patients. When due to the burn, volume loss causing hypovolemic shock or shift causing distributive shock has to be expected. So primary treatment will be fluids, this thing, but similarly you have to expect a organ perforation. Most common organ to be perforated is esophagus. So in those patients, you can palpate and look for any subcutaneous emphysema. If at all there, if at all subcutaneous emphysema, you can get it in neck. You can expect tracheal injury, laryngeal injury, and proximal esophageal injuries can be expected in those kind of patients. Okay. Any other reasons why patient can be severely tachypneic without much desaturation?
Acidosis.
Yes. Patient can go into acidosis as such. Primary metabolic acidosis as well as lactic acidosis both can be seen. Because of that compensatory mechanism, patient can be tachypneic. In those conditions, patient saturation will be usually normal and any chest findings that you will not get. Okay. So this is circulation part. What about disability?
GCS and sensorium.
Usually disabilities will not be affected as such, but any patient who has ingested, you should assess their eyesight. As we have talked about fumes, patient can have corneal edema, conjunctival ulcerations, corneal edema and blurring of vision can be there. So ophthalmology consultation for corneal ulceration, conjunctival ulcerations should be given from ER side. So other than that, disability as such, it rarely causes disability problems. Now exposure, patient has to be exposed completely and should be given continuous irrigation with sterile water or saline, whichever is affordable, isn't it? So this is the primary management of alkali acid ingestion in ER. Initially, but along with this, once you are done circulation and your cannulas are in place, what is the immediate management you should give? IV fluids, obviously, that is needed, but what is the immediate concern for the patient? For the patient, not for us. Pain. Patient's main concern is pain. Patient will be in one very bad condition of pain. You need to give adequate analgesia. Some patients may even have to be sedated. So mild sedatives can be given along with strong opioids for pain relief. Any patient who is getting intubated obviously will be on sedative infusions. Okay, so pain relief has to be kept in mind, should not be forgotten. Other than that, what are the other things? In this case, you told, no, we gave a GA medicine consultation. Why you want a GA medicine consultation?
Because we have to go for early OGDscopy in such cases. Because
why you want the early OGDscopy?
Because the tissues will start becoming more friable.
Yes,
perforation chances will increase.
As we told earlier, after 24 hours, the tissue integrity reduces. So any instrumentation you do after that time will has higher chance for perforation. So if at all you get a patient after 24 hours of ingestion, it is ideal to wait to 3 weeks before you go ahead for OGDscopy. Now, why do you want OGDscopy? For example, this patient, no, you told he spit or he bite on the tablet and immediately he spit it out. So why you want OGDscopy?
This is because of only prognostication. Whether if there is any chance of development of stricture later, means if there is any ulceration, he will ultimately develop stricture later. So we have to do the OGDscopy and rule out. We can prognosticate the further disease progression.
Correct. So as we told earlier, the whatever injuries has to be happened has already happened because it happens within seconds. But you are doing OGDscopy to assess the risk of the patient and assess the grade of ulcerations and all, and seeing whether patient will require esophageal stricture in the future. In this case, already during intubation, you are told vocal cord edema and laryngeal edema was there. So definitely he has some exposure of alkali onto his oropharyngeal area. So we don't know whether he has ingested or not. He told he has spit it out, but some amount of alkali can be there in saliva, which can rule down and cause these injuries. So early OGDscopy to assess whether any perforation is there. That's the first concern. If perforation is not there, what is the extent of ulceration, grades of ulceration? If no ulceration, whether burns are there or not. And if ulceration like burns are there, then we should prognosticate to the bystander that patient will develop strictures in the future and will require esophageal dilatation. Okay. So that is a need for emergency endoscopy. So if this patient has consumed alkali and has severe burning sensation in esophagus and all, what are you going to do for nutrition? Patient cannot take orally, right? So what will you do?
Parenteral nutrition.
Parenteral nutrition, if patient is coming to you after 24 hours and doesn't have a rise tube. So in these patients, as soon as you secure the airway, or if you don't have to secure the airway, but there is no indication to secure the airway, the patient rise tube has to be inserted as soon as possible, because otherwise patient will have to be on parenteral nutrition up to 2 weeks till the wounds heal. So early rise tube insertion and securing is ideal. If you have OGT support, it will be ideal to be put under the guidance of OGTscopy. But you don't have to wait for OGTscopy if you can, your OGT team is not there to back you up. You can put it blindly within first 24 hours. Okay. But when you put rise tube, you have to be very gentle. You should not push the rise tube roughly, because it can cause perforation, because already friable mucosa. Okay. So once rise tube insertion is done, what type of feeds do you want to give? What is the ideal dietary requirement for this patient? High protein rich diet is what we need to give to the patient. Now, you have secured the airway, you have started fluids, ruled out shock, and you are given adequate analgesia, you have sedated the patient. Now what else has to be done? You have planned for rise tube, OGTscopy, everything. What else?
Antibiotics, prophylactic antibiotics have to be
Prophylactic antibiotics should be given for any caustic or caustic ingestion of agents, be it acid, be it alkali. Prophylactic antibiotics should be given, because these patients can develop perforation later in 48 to 72 hours perforation and can develop mediastinitis. So prophylactic antibiotics which can cover a gram-negative and gram-positive coverage antibiotics should be started. Okay. So if at all this patient is having significant amount of caustic injury ingestion, and during intubation it was very difficult to intubate, what other investigation can you do other than OGTscopy to assess mediastinitis or esophageal perforation or pharyngeal perforation? CT contrast enhanced CT can be done. Contrast enhanced CT, neck, chest, and neck and chest is more than enough. Do you have to go for abdomen? Why? Perforation is usually in esophagus. Why not in stomach? Because alkali, GI acids are there. So there will be somewhat of neutralization of alkali once it reaches stomach. It's not like completely it will be neutralized, but somewhat neutralization will be there. So usually alkali injury in stomach is much more contained in comparison to the alkali injury of esophagus. So usually gastric perforations are very unlikely, and duodenal perforations and intestinal perforations are very unheard of. Okay, so basically you are expecting a upper GI involvement, esophagus and oropharyngeal aerial involvement is what you expect.